interested in social work or nursing or educator CEUs, I know we had one email about social work CEUs. We are working on that. It is a process. And so we are looking into how to make that happen. If you are interested in that, if you will please either include that in your evaluation or send us an email after the fact. I'll drop my email in the chat, as well as Taryn's, and we'll begin to collect those emails and get back with you as soon as we can. But that is something we're actively working on. We just really need to see what the interest is. And so we can kind of make a cost benefit analysis, and see if we need to ask for more funding to do this, to continue this work. So with that, I'm going to pass it off to our health educator, Megan Lyle, to introduce Dr. Smith.
Hi, everyone. I'm Megan. I use she, her pronouns. Thanks for being with us this afternoon. And thank you, Dr. Smith, for doing this awesome webinar. I'm really excited to hear more about your research. So just to give you a little background, Dr. Smith is an assistant professor in the Department of Health Behavior at UAB. She earned her bachelor's in human development and family services from the University of Alabama, master's in counseling psychology from the University of West Alabama, and her PhD in health education and promotion at UAB. Dr. Smith's former work as a social worker in the state of Alabama inspired her to focus her research on first-time parenting and adolescent parents. And her research advanced to developing interventions that identify protective factors to decrease sexual risk behaviors that lead to HIV and STI acquisition among African American adolescents and emerging adults, and exploring treatments as prevention for people living with HIV. And so I will just pass it off to you. Thanks so much for being with us. We're going to have time for questions and maybe throughout, but also at the end, we'll have time for questions. So thanks again.
Thank you. Thank you, Megan. I am Tamika Smith. I use she, her pronouns, and I am so thankful and grateful that you have invited me for this talk. So I'm really excited to dive right into my work and talking a little bit about HIV and acquisition and what that looks like. So thank you again, and thank you for the wonderful introduction. And so what I'll do is well, you did a great job running down the what. And so what I did was add a little bit of extra about things I like to do, and traveling is definitely one of them. My last travel was to Nashville. It was my last hurrah with my 10-year-old son before he started school. And so I love to travel, and I also love to crochet. I don't get a chance to do a lot of it, but I started a blanket that hopefully will be done by Christmas, but so far I'm not doing too good at that. But before I get into the talk, I wanted to talk about this article that came across my email this morning, and I thought it was so fitting and perfect. It came from NMAC, and it talked about the story of Ryan White and Michael Felton. Now, I am very familiar with the story, the Ryan White story, and the many HIV/AIDS prevention treatment efforts that have stemmed from the fight, right, of Ryan White. But sadly, I had not heard of Michael Felton's fight. And so Michael Felton had the same trajectory as Ryan White. They both needed blood transfusions, from treatment of hemophilia. They both fought to destigmatize HIV and AIDS. They both fought to just go to school, right? But Michael died at the age of 14 in 95, just a month, less than a month before he won the fight to attend high school, his freshman year of high school. And Ryan White died at the age of 18, just 5 years after Michael Felton. But this article continued to talk about the need to make widely known August the 20th, which is being coined as Southern HIV/AIDS Awareness Day. And the purpose of this day is just to bring attention to how the HIV epidemic disproportionately impact the southern states. So I just wanted to share that with everyone and do my part about spreading the word of August the 20th. And I thought it was so fitting today, right before I was going to speak to you guys today. So let's get right into it. What are we going to do today? We're going to talk about HIV rates, not STI, HIV rates globally, nationally, and then what does that look like in the South, particularly where we live, how these differences impact sex and race nationally and locally. And then I'm going to summarize some projects that I am doing at the moment. So the Beehive Project, the City 2 Health Project, and then there's one that's not HIV focused. However, it does talk about how we train practitioners and folks who work in that public health space. So it does fit. All right, so let's take a look at this global picture. All right, and so we're looking at these trends starting from 2010, and we can see globally the rates are declining. So if you look at 2010, there were 2.1 million, right? And then almost half to 14, and then again to 13, 1.3. So we're seeing a decline in these rates. But when you look at the individual regions, you can see where some of these regions are increasing. If you look at the Eastern Mediterranean, and these are countries such as Israel, Egypt, Turkey, right? There is an over double increase from 2010 to 22, and then it continued to increase, right, in 23. And so what this does is it allows us to take a look at where some of these efforts, these HIV prevention and treatment efforts, right, can take place from a global lens. And so there is this initiative, Ending the HIV Epidemic, EHE. And so what this initiative states is that by 95% of people living with HIV should know their HIV status. So 25% of people. And so in 2023, we have reached 86% of those. And so what we need is about 3.4 million people. So when we say we've reached 86% of the 95, it sounds really good and we're making really good progress. But when you want to put that in terms of people, that's about 3.4 million people that still need to know their status. And so the second 90, right? Because it was, according to where we are now, it's 90%, right? And in 23, we reached about 77% of those individuals living with HIV have received their antiretroviral therapy. And again, looking at the number of people, we're looking at 5.4 million people. And then the last initiative, which is the 86%, we're looking at 72 of that 86% of individuals living with a suppressed viral load. And so we are at 5.6 million people there. Sorry, I'm going backwards. Oh, all righty. Maybe I should use these arrows instead. Okay, sorry about that. So now let's put this in terms of adolescents, right? And when we talk about adolescents and HIV acquisition, when we're looking globally, right, we see a growing number. So in 22, there are about 1.7 million adolescents between 10 and 19, right, that were living with HIV. And when we think about the adolescent population, they're accounting for about 4% of people living with HIV, which is a relatively small percentage. However, when we put that in terms of new HIV acquisition cases, they're making up about 10% of these new cases globally. And so HIV continues to be like a major global public health issue. Since the beginning, since the epidemic started in the 80s, 88.4 million people have acquired HIV. And since 2023, there's 1.3 million who've acquired in just 2023 alone, okay? So since 2010, so the number of those acquiring HIV is reducing. It's reducing by 39%, and that's great, right? However, HIV is claiming about 42.3 million lives, even though we're seeing this decrease. We're seeing this decrease at a national level. And so with that being said, we're going to take a look at what this HIV acquisition look like nationally. So we did the global picture, but what does this look like nationally? And so we're still going to target with the EHE goals, right? Ending the HIV epidemic. Nationally, the goal was to reduce new infections by 90% by 2030. And so what the national level did, they wanted to focus on these jurisdictions, right? They didn't necessarily take it from the 95, 95, 95 or the 90, 95, 90, 86%. However, looking at these global national hotspots where there were an increase of HIV transmissions. And if you take a look at this map, you can see where some of these transmissions are statewide, right? So we see Alabama, Mississippi. And so this entire state was focused as an HIV hotspot, right? And then those that are the lighter blue colors. And then if you take a look at these green spots, these are counties, and these where HIV transmission is high. And so the EHE initiative was focused in these areas of hotspots, HIV hotspots. And so once EHE took the initiative from a jurisdiction, they also thought about these priority populations, right? So they had this additional focus as well. And these were populations that were disproportionately affected by new HIV cases. And so those populations were MSM, men sleeping with men, and this is particularly among Black American, Hispanic and Latinx American, American Indian, Alaska Native men. And then there were Black American women, women of trans experience, and then our young folks, 13 to 24, and then those who inject drugs. So this was EHE's priority populations. And so now the next couple of slides, we're going to really dig into what exactly does these new HIV cases look like in the US. And so this is a graph by age. There were about 31,000 new cases. And we see that the EHE goal here at the bottom was to decrease this number, right, to 9,300 by 25 and 3,000 by 30. And so we have a ways to go, but hey, that's our challenge, right? And we're going to continue to accept this challenge. And looking at the age range 13 to 24, this is where a lot of my prevention and intervention efforts lie. We're they're the third, and where the highest is this 25 to 34 range, and then 35 to 44 being the next. All right, looking at the next goal, which is decrease the number of new diagnoses. Here, we're at 37, about 38,000. Again, we're looking at 96 by 25 and 3,000 by 30. And again, that 25 to 34 range is really leading the numbers there. And then again, third group would be this focus of 13 to 24. And then knowledge of your status, right? So how many HIV tests are being conducted in order for individuals to know their status. We're looking at 87 out of 100 people knowing their status. I consider that a pretty good, promising number, considering the stigma that's associated with receiving an HIV test. But the goal there was to increase the percentage of those who know their status by 95%, and then holding steady between 2025 and 2030 at that 95%. And then, so when we're talking about the goal of increase of percentage of people who are diagnosed with HIV, having a viral suppressed load. And some things to have a viral suppressed load is to being adherent to your medical care, adherent to your medications. And so when we look at per 100 people, 76 of 100 people receive some sort of HIV care after receiving their diagnosis. All right, and 54 were retained. So a little over half of that 100, and then 65 of that 100 were virally suppressed. And again, when we look at the target goals of 95 and 95, it remains the same from 2025 to 2030.
Dr. Smith, I wonder if you can just take a moment to tell us. I know what virally suppressed means, but I don't know that everyone does. If you could just take a minute to let us know what that means.
Yes, so virally suppressed is when you have your HIV status, you can no longer transmit the infection between partners. You are adherent to your medications, your treatments, your doctor's appointments to the point where you cannot transmit. Thank you. All righty. And so now looking at these cases by sex and age, we look to the left, we are about 31,000 men to the 7,000 women, and these are HIV diagnoses in the US. Again, that age range, 25 to 34, are the leading age ranges. And then lastly, we're going to talk about what does the trends look like, right? So from 2018 to 22, we see the 18 is the small blue dot. Hopefully you can see that. But the arrow is the 22 data, and it shows you the direction of the trend. So again, my interest is adolescents, emerging adults, 13 to 24. So we see an 11% decrease in new cases. And so that's very promising. Again, that 25 to 34 range is where a lot of these new cases are happening. There is an increase, and then there's an increase about 5%. I will say this, though, is where you see these 27% of 12 and under, it's important to know that when you already have a low number, any increase may look like it's a large increase. All right, now that was the national picture. And like I said, we're going to talk about the local picture, and then we'll get into some intervention efforts to address some of these new cases that are happening. So there are 11 counties in Alabama that have rates considerably higher than the national average, right? In some cities, their increase in HIV rates happened in like urban areas, but for Alabama, ours are more in these rural areas. And so some of the highest cases happen in Perry, Dallas, and Lowndes County here. That's shown with this red square. And then, of course, over here, these newly diagnosed cases. I'm going to present the next couple of slides, data that reflects from, it's ADPH data from January to June. However, I would say kind of interpret that with caution because they're still entering data in their surveillance system. But these are the most up-to-date numbers. And so with that being said, to date this year, we have 245 newly diagnosed HIV cases, and that is happening among Black Americans, males, and again, the age range here is that 20 to 24, followed by the 25 to 39. So again, that 35 to 44 range there, a little bit younger in Alabama than the national and the global rates. All right, and this is by district. Again, when I talked about Lowndes, Dallas, and Perry counties being one of the higher transmitted rate counties. As you can see here, the East Central have the most of this 245 cases at 68 cases. Jefferson County falls second with 43. And then looking at Birmingham. So now we're taking that local picture from Alabama down to Birmingham. And in 2021, we had about 5,000 individuals living with HIV. And then we wanted to look at how many of that were our younger folks were in their 20s. There was about 490 per 100,000 people living. But when we talk about new cases, that was about 13 new cases per 100,000 of younger individuals in their 20s being diagnosed. There is a decline from 2017 to 2021 of new HIV cases in Birmingham. And then this is 2020 population rates, just looking at the prevalence and the new diagnoses here. Again, looking at males, Black or African American, and then that age range of 25 to 44. And here, this is transmission, prevalence, new diagnosis, HIV transmission. We're looking at, when we look at prevalence here, I thought this was very interesting. Male to male contact was about 65% here, the prevalence. But when we got into like new diagnoses, there's a huge unknown category of 60%. And again, remember I said this was this year data from January to June. And so there may be a catch-up game there that may account for this unknown. All right, and so HIV is most commonly, transmitted from sexual contact, sharing of needles, but both of these are very behavior driven, right? They're associated with human behavior. So if we can change behavior, then we can change these HIV rates, right? But that's simply stated, but it's not easily done, right? Health behaviors are very hard to change. But as, public health folks, as social workers, that's our passion. And so we readily accept that challenge. And so I'm going to use the remainder of this presentation to talk about some of the projects that I have worked on and led, and how I tried to address some strategies to hopefully change this sexual health behavior and hopefully reduce like HIV and STI acquisition. So switching a little focus from being very data heavy to being projects, okay? So I want to start off with the Beehive. Well, it says Beehive 2, but I can't talk about Beehive 2 without talking about the Beehive, the original. So the Beehive is an intervention. It's an HIV prevention intervention. We like to call it an edutainment video intervention. It was 9 videos series. It was developed for 18 to 25-year-olds, African Americans, and they were living in Birmingham. The PI of this project was Susie Davies, and this project was funded by the CDC as part of being one of CDC's Prevention Research Center, the Center for the Study of Community Health at UAB. It was the core research project. And so some of the goals of this project was to, on the short term, increase HIV knowledge, right? Help the participant understand their perceived risk of HIV, and then increase self-efficacy towards condom use. Intermediate was, we wanted to, again, increase condom use, increase HIV testing uptake, and then, of course, reduce some of these sexual risky behaviors, such as having more than one sexual partner, using drugs or alcohol before sex. Okay. And then long term, we wanted to reduce HIV and STI transmission rates among our target population, which was that 18 to 25 African American individuals living in Birmingham. Reducing HIV AIDS related stigma. Establish that social media is an actual pretty good platform for disseminating sexual health information. And then again, kind of contributing to improving population health and eliminating those health disparities. And so what the Beehive did was we had musicians and they were paired with HIV experts in these 9 video series. And so how we got the the musicians was we did 95 intercept interviews on the street in Birmingham, notepad and pencil, and asked the people of Birmingham, hey, what are your local artists? Who do you listen to? What kind of music do you like, right? And so that allowed us to compile a list of local musicians that could be in our video series. The artists, they volunteered their time. So, funding was a little tight, so we couldn't pay the artists. And then some artists worked on the series beyond the episode. There were some activities that happened after the intervention that some artists stayed and participated in those things, like a concert, a watch party, because some of them had not seen the intervention, right? And so we used music venues around Birmingham to record these music sessions, these Q&A sessions. All of the venues donated their time. We wanted to provide a casual setting to have these HIV discussions. And so different music venues around Birmingham were used. And then we also had HIV experts. These were clinicians, health educators, people living with HIV. And we paired them with the musicians and they had these Q&A sessions. Everyone volunteered their time. And like I said before, the venues volunteered their space. And so just to give you a picture of what the population looked like from the Beehive, there were about 174 females, 152 males, 58%, so over half of them had some college education. Around 34% of them, they had an income that took care of their bills, but they just didn't have enough for extras, like going to the movies, eating out, and those type of things. About 33% of them were unemployed. When we asked them about their HIV knowledge, the mean was about 11. With a range of 1 to 18. So of course, the higher the score, the more knowledgeable about HIV the individual was. And one thing we did, this was about a 6 months process that the participant will be in our intervention. And so at the end of that 6 months, we asked them if they wanted to take an HIV test. We offered HIV tests. And about 75% of that population took an HIV test. Now, what we did do, because they all didn't take a test with us, we asked if they declined the test, had they taken one in that 6 month span and where had they gone, and they would volunteer that information. So that 75%, which a large portion of our participant, but that includes those who tested with us or some other testing site in Birmingham. And when we looked at risky sexual behavior, about 49%, so almost half of the participants did not use condom at last sex. 27% used some sort of alcohol or drugs at last sex. And then about 31 of them did not have a committed partner, but had like multiple partners. And so what we learned from this particular intervention was that females were experiencing higher STI rates than our males. Females were not using condoms as often as our males, and we're looking at 62% versus the 33%. That's doubled. The number of STIs were doubled. Males had more sexual partners during their lifetime. So where the mean was 12 for males, but 6 for females. Early sex initiation happened around 15 for males and 16 for females. HIV testing increased in both males and females. And we also found that HIV testing increased among our intervention and our control group as well. So yay that everyone decided to get tested, but when we want to look at intervention effect, that was not so yay. But we want the yay. But both genders were not a fan of the music. They did not like the music at all. And so what we did was we evaluated the intervention. And to our, well, I wouldn't say to our surprise, because remember I said the funding was tight. So we could not pay our artists. And so what we did was we said, okay, this is what we can do for you. We can give you studio time and you can make your first demo tape. Because these were up and coming artists. They were all trying to make it, right, in the music industry. And so we did not put any kind of guidelines on the music that they could make or record. And so unfortunately, what they did make was counterproductive of the message. A lot of profanity, a lot of, it just did not support the message of safe sex, reduction in partners. It just didn't. And so our target population was not a fan. So understanding how meeting your right participants, your population where they are, we're like, well, how do we revamp this 9-video series to reflect what we found in the evaluation and in our data? We were looking at initiation age at 15 and 16, where our population started at 18. So how do we address a younger demographic and clean it up, for lack of a better word? And so that's where the Beehive 2 comes in. This was funded through Community Health Scholar Pilot through the Center of Community Health from UAB. We partnered with AIDS Alabama, and we created this shortened video of these 9-video series. And this, we reduced it down to a 12-minute video. We had a series of meetings with some of the staff members at AIDS Alabama and said, hey, here's our 9-video series. We would love to make this shorter per evaluation from our population. How do we do that? What is it that you can see this video in your space and educating your clients? How do we make this more attractive, right, to them? And so we reduced it down to 12-minute video. We reduced the music drastically without losing its entertainment component. So there was still music in it. There was some spoken word that was in it. There was these Q&As that happened in Railroad Park. So that was some of the things that our participants said were very good parts of the videos. So we left that. We reduced the age actually down to 12 to 24. And knowing that early initiation was happening at 15 and 16, then we want to educate before we get to 15 and 16. And so we reduced that age to 12. Again, I said we work with the staff to edit the video, and also we asked questions. Well, we will ask, I'll tell you where we are with this, questions on disseminations. Where do you see this video in the community? Where do you see this video in your agency, right? It says currently collecting data. We're stalled by IRB, and as soon as we get that ironed out, we will continue to collect data. That's just one of the challenges of doing community-based research and using the community to collect your data. Sometimes you just have roadblocks. But here's a QR code of the 9-video series. We do not have the shortened video up just yet because we are still wanting to test it, right? So we don't want it out. We'll roll that out once we finish testing that short video. So if you have a moment, you want to take a screenshot or you want to scan the QR code, you can see those videos of the Beehive, and then you can kind of understand firsthand like what exactly was I talking about the music. All right. Okay, next project. This is HIV care and services during the national shutdown. This, I forgot to mention, I am the PI of the project, the Beehive 2, and I'm also the PI of this particular project. And this was funded through the Deep South Rigmar. And the idea of this project was to focus on continuing that HIV and care services during a national shutdown. And I'm saying a national shutdown because we know that was COVID, right? But I want you to keep in mind that, there's many shutdowns that can happen, whether it's natural or man-made, right? I always like to say, we live in Alabama. We have tornadoes all the time. And sometimes, like, we have to end our day, our work day, go get a kid from school because they're about to shut down or whatever it is. But when this happens, how do we continue our HIV care and services? And so this project was a collaboration again with AIDS Alabama. And we wanted, well, AIDS Alabama, what they do, first of all, the services they offer are a lot. It's a lot, right? And they take this holistic approach. They have HIV and STI testing, prevention, treatment, housing assistance. They made a pivot to COVID-19 when COVID-19 happened. Mental health services, so just off transportation, just offers so many services. And so their campus, we are partnering with El Centro, the hub, where we're doing our collection of data, and which is a safe space for their clients. And then again, we worked with them for over 10 years. We worked with them during the Beehive 2. So they just seemed a obvious partner for us for this project. And so these are just a list of the services that they offer. There's these services for folks living with HIV, and then of course these prevention services. And keeping in mind, like COVID, like these services for the most part stopped, right? And think about how important emergency housing is, right? How important is this mental health counseling? Linkage to substance abuse treatment, right? PrEP, testing, like all of these things, either completely stopped or they were reduced greatly. All right, and so the need. So before COVID, they served about 140 clients a week. That number went to 36. All right, and again, thinking about those services from the previous slide, right? And so they were navigating through these spaces uncharted, right? They had to implement these impromptu strategies. Some of these services we just cannot discontinue. We can't pause on medication drop-offs, right? We cannot not do that. And so by reducing their services to these emergency prevention and treatment services only, so everything was emergency only. And so the goal of this project was to determine the impact of the shelter in place in Alabama on people living with HIV receiving these services and prevention of treatment. What was the impact of this shelter in place on providing prevention and treatment? So receiving and providing, right? And so what we did, is that on the no, it's in the next slide. Okay, and then develop a disruption in care process, procedure. Ultimately, that is what we want to do, right? We want to take all of this understanding of these lived experience of individuals living with HIV and receiving services, individuals providing, right, these services. And then again, taking that information, how do we use it to develop a process? And so that happens in 2 phases. We are targeting 75 Black and African American clients receiving services, HIV services, 1 or more services. They had to have been receiving services 6 months prior to the shutdown, during the shutdown, and then 6 months after, so that we can really get a good picture of what that looks like for them. And then also, we did one-on-one interviews with about 25 of that 75. So the 75 were surveyed and the 25 was interviewed to get, more qualitative understanding. And then so we also interviewed 10 of the staff members, and they worked in prevention, social work, counseling, programs such as transportation, housing, because we also wanted to know how was it working with during the shutdown, knowing that you had to worry about your own safety, but try to continue this very important work, right, of providing services. And then again, I mentioned phase 2, where we're going to come up with this development of these procedures, this process, and we'll do a different 10 AIDS Alabama staff members to work together to pull together the data plus their own experiences of how do we navigate a shutdown in the event that this may happen again. Where we are, so we're still in phase 1. We are using 3 of AIDS Alabama staff members to collect these data. We have 32 of the 75 surveys, 8 of the one-on-one interviews. Myself and the research assistant are conducting the staff interviews because we don't want the staff to interview the staff. We want someone outside, which would be myself, to come in and interview. And we have 6 of the 10 of those completed. It was very interesting hearing from the staff working through that time and some of the resources that they had to either get from the agency themselves, or some that they didn't know they necessarily needed until they had to work from home. Was very interesting. But next steps, we're going to work again with the additional 10 staff members to figure out these shutdown procedures and use client and staff results from phase 1. The next steps for this project, I'm really hoping that we can take this process and test it or implement it in other ASOs around Alabama. Like, is it just specific to AIDS Alabama, or can we do this at BAO? Can we do this at Five Horizon? Can we do this in Selma Air? So that's a next steps hope. Alrighty, and then lastly, I want to talk about the health equity simulation in the classroom. This project was a product of my participation in Healthcare Educators Academy at UAB. And it was associated with how do we end inequalities in the healthcare system. So again, indirectly focused, right, to HIV, because we are training and molding healthcare professionals and practitioners, right? How do we eliminate these biases, right, as we are serving our individuals? And so what this was a computer based simulation that students who were enrolled in these courses, also if the student or individual was recommended by their professor to participate in this simulation, and students completed a pre-test, they did the simulation, and then they had a post-test, which was survey-based and qualitative with a reflection. Using the C, which is the scale of ethno-cultural empathy, where we looked at empathetic feeling and expression, our perspective of individuals that were different from you, acceptance, right, of different cultural backgrounds, and then empathetic awareness. So there were about 31 items on this scale. Like I said, they did the simulation, then the post with the reflection essay. And so this is just a screenshot of the simulation. And what happens is you are presented in at the emergency room with back pain. And you are asked to navigate this simulation, and you have choices to make. You have feelings to express and rank as you're navigating this emergency room, and you're faced with some pretty tough challenges of just trying to get treatment. You do not know what you look like as you're going through this simulation until the very end of the simulation. Right, and so what we've learned, we've collected data from 43 students from public health and students from social work at UAB. Of the 43, majority were female, like 73%, which is pretty telling of classes and class makeup. 21 years of age, and then about half of them were white students, and over half of them at 67% classified themselves as an undergraduate student. Over half, 67% again of the learners perceived the issues of inequality in healthcare setting very relevant. And 60% of them were very sympathetic about the inequalities that displayed in the healthcare setting. That is the last project that I have, and that is the end of my presentation. And so now I am going to turn it over maybe to Megan or Christina.
Yeah, thank you so much. That was amazing. It's so exciting to hear about all the work that you're doing, and also some of the pictures. I noted, like, I recognize people that we have worked with in the past or that are on the board. So that's really cool to see too. Of course. I
Nice.
have some questions, and then I don't know if Megan has any, Megan or Taryn. There was a question in the chat, and folks, feel free to drop your additional questions in the chat, but I'll highlight this question first. So there was a question from Barbara about, this is going back to maybe the middle of your presentation.
Okay.
What is the educational level of those being diagnosed in those counties? And the counties you were talking about at that time were Jefferson versus the kind of the black belt counties that you were talking about, the Lowndes, Dallas, and there was one other one that I can't recall. Also, income of folks who were being diagnosed. And then the final question in that question was, what was the difference in resources compared with those being diagnosed in Birmingham versus those in Lowndes and Dallas? That one I can answer. Birmingham is very, very highly resourced. And, you know, urban city in the state, one of the biggest urban cities in the state, versus I know Lowndes and Dallas are more under-resourced. But I wonder if you can speak to the other things in terms of income level and educational level.
Okay, so what I do know about those counties is that there is a low income range, right, in those particular counties. Now, I have not looked at the education, but when you want to think about disparities and how certain factors, right, are linked to each other, and we can say that education and income are linked. So with that low social economic area, I would also, with caution, say that I would say the education would also be low there as well.
Yeah, thank you.
Yeah.
So going back to some of the questions I had, so early on, and I think you kind of answered this towards the end, but so I know about the prevention efforts that you're using with young people and the work that you're doing, but what have you found to be the most, like, what is the most effective when working with that younger age group, that 13 to 24, in terms of preventing an initial HIV diagnosis?
That's a tough one because there are a lot of factors at play, right?
Yeah.
One of them definitely is like the support system surrounding mainly the parents, right? Or caregiver, whoever's caring for these younger individuals. And I didn't even talk about these. I did a series of workshops with families and their 11 to 16-year-olds. And these modules, there were 8 modules, and the last module was a sexual health module. And it was the most not looked forward to module there was. But the thing is, the first thing I did with this is like, who's ready for this conversation? And almost 100% of the parents, no, they're not ready. What I found surprising is that some of those 11 to 16-year-olds would raise their hand and they would say, hey, I'm ready. So sometimes it's just the plain old communication. It's asking, do you want to have this conversation? Are you ready for this conversation? Of course, that makes us as parents very nervous to do, because of some of these myths, right, that still plague our thinking when we talk about sexual health education. One being that if I talk to my child about sex, that means that they're going to want to, increase or be curious enough to start. But communication, meeting them where they are, it's not necessarily that let me sit you down and talk to you about the birds and the bees type communication that may need to happen. Sometimes it's the one single question, hey, do you know how to use a condom? Do you know how to ask for a condom? And then it doesn't have to be a whole 20-30 minute conversation. Sometimes it's not the parent themselves. Sometimes it's that health educator, right? Hey, is it me that you want to have this conversation with, or is it this health educator you want to have this conversation with? Let's find someone. Or do you know anyone? Or maybe you can ask your friend. Peers are major influences for our young adults and our adolescents. But unfortunately, peers can also share misinformation, right?
For sure. Yeah. And I mean, that's obviously in the South, in Alabama, if they get anything, it's an amazing thing, right? If they get any information from a health educator or school situation, it's an amazing thing. But sometimes even that can be like really laden with values and an opinion and not just fact, which is something we're fighting back against. So it's good to hear you say like we could just have these conversations. We could be in a better footing, because I think that's very true, and like true
Yeah.
of sexual health work in general.
Yeah, it was eye-opening, but you mentioned school, sexual education in school, and that was the first thing I opened these workshops, well, that particular module with, and I said, you know what? It's not the law to teach sexual health in school. And if they decide, the school has to decide, right? If they want to provide it. And if they decide it, it has to be abstinence only.
Yeah.
So
Right.
where are they going to get this information from?
Right. Yeah. And so the thing that we, the work that we do a lot is educating folks on the law, because they can talk about more than abstinence, but so few teachers are willing to do that because the law is written in such a way that they're worried about their jobs. But even if that weren't the case, there's no support from higher ups in the Department of Education. And so they have no support that would back them up if they were to teach anything besides just abstinence. And even abstinence, we've learned in this last year, but some folks don't want any messaging about sex, not even abstinence. So it's very interesting. I do want to get to one other comment or other question. Do you have any recommendations for those of us working outside the South to better prioritize and reach people from the South? Perhaps cultural or environmental differences we may not be familiar with.
Collaborations. It's one of those things where in order to serve the individuals you want to serve, you have to have them at the table, right? And I always say not just at the table, but a safe seat at the table, right? And from the beginning, not as you have already formulated your strategies that you're really excited about, but doesn't mean you can't share them with them, but brainstorming with individuals from the South, from the South, from the beginning, asking, tell me, first you need to know their priorities, right? What's really important to you in addressing, because we can't address sexual health when they're trying to figure out how to feed themselves, right?
Right.
So collaborations, partnerships, from the beginning, mutual respect, and prioritizing.
Yeah, and I will second that and just say, as somebody who is a Southern transplant, I've been here for 13 years now, so I feel like I'm not quite Southern, maybe. I wasn't born and raised here, but I'm all but Southern. It is hard to go into spaces where folks don't know what the South is like and what living in the South is like. And then to have them try to tell us what would be a good idea for us. Because we're like, that's not gonna work. We can't even get a teacher to talk about sex.
Yeah.
So I second everything you just said about collaboration. Any just like a burning question with the 1 minute we have left? Any other burning questions?
We did get a couple of questions just about the resources. So if you wouldn't mind emailing me the like article you mentioned at the beginning, and if you feel comfortable sharing your slides, we could also send those out. If not, then that's fine.
Sure.
But yeah.
All right. No
well,
problem.
thank you so much, Dr. Smith, for being here. I just wanted to highlight one other comment. Thanks for the info and perspectives. I didn't realize how stringent and restrictive many things are in the South, especially Alabama. My folks were born and raised rural near Lowndes County. So yeah, that's definitely a part of the state that is under-resourced and needs a lot of collaboration to work with.
Yes, definitely.
Yeah. Thank you so much, Dr. Smith. And thank you all for being here. Hopefully you've seen our request for you to fill out the evaluation in the chat. I'm going to drop it one last time. Please take just a minute to do that. It'd be so helpful. Thanks, everyone.
Thank you so much, guys.
Thank you. Have a good day.
You too.
Thank you.